Good afternoon, everybody, and welcome to the Maternity Matters webinar from Owen Mitchell, which is on the treatment of Group B Strep in a clinical setting. Thank you all to everyone who's given up their time to join us today, and obviously thanks very much to all our speakers for taking the time to give up their time to speak to you about Group B Strep. We've got a great lineup of speakers today, focusing on the care provided both in the antenatal and labour management of Group B Strep. We'll be hearing from Julia Parvia, a midwife. We'll be hearing from Myles Taylor, an obstetrician, Dr. Rennie, a neonatologist. We'll also be hearing from a client of Owen Mitchell, who will give an insight into her story about having a child with Group B Strep. We will then have a question and answer panel question, and then we are hearing from NHS Resolution, where we have Rachel and Annette, who will be speaking to us from their perspective, followed by myself, who will be giving a few case studies, and then we will be going to Dr. Jane Plumb from Group B Strep to talk to us from her perspective. I will introduce each of the presentations beforehand, just to let everybody know that the talk today is recorded, so this will be provided to everybody to share afterwards. There are some parts of the talk which are confidential and they will not be shared within the presentation afterwards, so if you are missing that information, please do feel free to get in touch with us and we can advise further on that. Just to say also, there is a question and answer part of the Teams channel, so please feel free to type in as many questions as you like and we will do our best. We have 2 question and answer slots. The first will be a combination of Jane, Myles, Janet and Julia, and the second will be Jane, Rachel and Annette. If we can't get to your questions today, please can I ask you to put your name and contact email address so that we can respond to you after the presentation in case we don't able to get to it. We've had a number of questions in already, but also please do send them throughout the presentations. So without further ado, I will hand over to our first speaker. Julia is a qualified and registered nurse in 2003 and became a midwife in 2005. Julia had an MSc in midwifery and BSc in midwifery and a diploma in nursing. She specialises in community midwifery-led care and is currently a senior midwife at her local NHS trust. Julia has managerial experience and clinical responsibilities, which includes working in teams of midwives and coordinating the midwifery-led unit. She involved in safeguarding women and babies and has a wide social and cultural community experience. And her talk today is going to focus in 2 parts. Firstly, on managing GBS in antenatal care and labour, and then talking about the management of records, what should and should not be documented as a consequence of not documenting. Thank you.
Hi, everybody. So my presentation today is going to look at the roles and responsibilities of the midwife in the antenatal and intrapartum period. Next slide, please. So who am I? My name's Julia Parvia, as Richard introduced me. I'm an associate trainer for Somac & Associates and a midwife for 19 years. Been an expert witness for 5 years and undertaken 100+ cases. My areas of specialism are mainly community and low risk birthing centre, which I coordinate, intrapartum care, low, high risk, and all aspects of postnatal care in hospital and community. Next slide, please. So the purpose of my presentation today is going to give an overview of what Group B Strep is and the relevance of this within pregnancy. I'm going to give an understanding of the observations and tests that are carried out during the antenatal period and the detection and plan if GBS is found in the booking or subsequent urine samples throughout pregnancy that we take, or the detection and plan if GBS is found on a swab during pregnancy. We're going to look at pre-labour rupture of membranes for GBS positive women. And then the second part's going to be documentation within pregnancy records and the discussion that should be held within women throughout the pregnancy when they are Group B Strep positive. Next slide, please. So Group B Strep overview. So 1 in 4 pregnant women will carry GBS in their gut and or urinary genital tracts. 50% of babies of GBS colonised mothers will also be colonised with GBS. And 3% of the GBS colonised babies will develop early onset GBS. So it's estimated that early onset GBS in babies will cause more than 40 neonatal deaths and around 25 cases of long-term disabilities each year in the UK. And at the moment, the UK does not routinely test for GBS, and that's due to the lack of research data on the clinical and cost effectiveness of this and carrying out the routine testing for all women. So within the UK, women are offered intrapartum antibiotics based on maternal risk factors or a previous baby with GBS. And this is all in line with the Royal College of Gynaecology Green Top Guideline, which was 2017. Next slide, please. So the risk factors for Group B Strep and offer of intrapartum prophylactic antibiotics. So these risk factors would be having a previous baby with GBS infection, the detection of GBS in the current pregnancy, and that can be via a swab or found in a urine sample. And if GBS is found in a urine sample throughout pregnancy, antibiotics are prescribed at the time of the detection, as well as given in the intrapartum period. GBS in previous pregnancy, but the baby wasn't affected, a discussion should be carried out by the midwife to the woman to explain that basically she can still have intrapartum antibiotics and they offer a swab, and that'll be between 35 and 37 weeks gestation to see whether this current pregnancy has been affected by GBS. And that allows women just to make an informed choice of whether they want the intrapartum antibiotics. Next slide, please. So there's other indications for antibiotics in labour. So preterm labours, antibiotics will be offered regardless of whether a woman's GBS positive or not. So all women in preterm labour will be given antibiotics anyway, and this will include antibiotics to be given, the ones that would be given for GBS. Pre-labour rupture of membranes. So an induction of labour for women who are GBS positive, they'll be offered immediate or as soon as possible induction, and they'll be given the intrapartum antibiotics because they're GBS positive in the current pregnancy. So whereas if you've got pre-labour ruptured membranes for a woman who hasn't been identified as being Group B Strep positive, they would be given 18 to 24 hours to go into spontaneous labour, and then they would return for an induction. Whereas if they're GBS positive in the current pregnancy, they'll be offered as soon as possible, should be immediately given the option to have the induction. Any women that are pyraxial in labour, antibiotics prescribed will be broad spectrum, but this should include GBS cover. Next slide, please. So the discussion with women, and this is throughout the antenatal period. So this is your community midwives or midwives on the maternity assessment units. So if Group B Strep is found within the booking urine sample, which is always taken at the booking appointment, along with all of the blood samples and all the screening that's done for women right at the start of the pregnancy. So it can be from the booking urine sample or any urine samples that are sent to the labs for further testing. So if something's on a dipstick, that they send it away and then they find that they're GBS positive, they would be given antibiotics straight away for that, and then antibiotics in the intrapartum period. So this again would be followed by the intrapartum antibiotics, and this needs to be explained to the woman that this will be at the commencement of established labour, or if pre-labour spontaneous rupture of membranes occurs, the immediate induction of labour will be offered and antibiotics will be commenced. Next slide, please. So if a previous pregnancy has been affected by GBS, we need to discuss that with women, and we need to discuss and find out whether the previous baby was affected by the Group B Strep. So we need to discuss with them that there's an increased risk that the current baby may also be affected. However, if the previous baby wasn't affected by GBS, even when GBS was found in the previous pregnancy, there's a 50% chance that the woman will be carrying GBS in the current pregnancy. So enabling women to make a choice of whether they want intrapartum antibiotics when it's been a previous pregnancy that's been affected. They can have a swab which can be taken between 35 and 37 weeks gestation. And that's just to discuss with women that obviously then they would know whether GBS was in the current pregnancy or whether it wasn't. And even if it wasn't, and they did have it in the previous, they can still have the choice of intrapartum antibiotics. So it does just allow them to make a choice whether, it doesn't matter what the results are in the swab that's taken in the current pregnancy. If it's been in the previous, they can still have the intrapartum antibiotics. Next slide, please. So to make an informed decision regarding intrapartum antibiotics, women must be given all the information they require to do the same. And that's with anything that midwives do. So women should be given all of the information before anything's undertaken. So the discussion with the women is always just the starting point. You give women so much information that sometimes it's difficult for them to take everything on board at that particular point. And it's important that women have leaflets to take away with them so they can read, they can discuss things with their family. But in particular, we must, as midwives, make sure that these are always in the appropriate language. Women that don't speak English need to have these leaflets, or if you're having any discussions, they need to have an interpreter present. We need to make sure that women that don't speak English do completely understand, and they understand the implications if they don't have the antibiotics and what that means for their baby, just as any woman who does speak English. So there's an abundance of information on the internet regarding GBS and early onset GBS infection. However, midwives must remember that not all women have access to the internet. And even in this day and age, where internet is everything and, everything is electronic, it doesn't mean to say that every woman will have access to that. So it could be that when you do your, your talk throughout pregnancy and you do the, your birth talk, that, you spend time with women and you make sure that each woman understands everything that there is about GBS if she is positive or she's had a previous pregnancy. And like I said, this should be revisited throughout the pregnancy, ensuring that women understand, because just because what you tell them at the beginning of the pregnancy, they may not have understood then, or they may talk to different people who will give them different opinions. And you just need to sit down with them and make sure that what they relay to you is, a concise understanding of all of the implications of Group B Strep. Next slide, please. So the timing of intrapartum antibiotics, and this should be explained to women how antibiotics will be given and when they'll be given. So it ensures that women are aware that there's a process that will be followed. So when women are Group B Strep positive and they come into hospital in established labour, they will be cannulated at the onset of the established labour, or if it's pre-labour spontaneous rupture of membranes, and the induction is commenced immediately. So explain to them that a loading dose of the antibiotic will be given, and it's given through the cannula through a drip, and that's then followed by further doses, which are given every 4 hours during the labour, and that's through the same route as being a drip through the cannula. And ensure that women are aware that it won't affect them mobilising, and low risk labour won't be affected. So on low risk units, you can administer intrapartum antibiotics for Group B Strep, and they can come in and establish labour. They're cannulated by the midwife. They can still move around, and that they're low risk. It doesn't suddenly make them high risk where they're going to be continuously monitored, and that will only happen if there's risk factors that require that. And obviously there's women that will come in and they'll labour very quickly, or they'll come in fully dilated and we won't have time. to get the intrapartum antibiotics in. So this is where, going back to the antenatal period, it's really important for midwives to go through every eventuality, so that if women come in and they're in established labour and there's plenty of time, that, you know, the antibiotics will be given, like say, the loading dose, then every 4 hours thereafter until delivery. But if we don't manage to get them, it's important that women realise that then what we would offer is observations for the baby. So, and that would be 12 hours. So, and that would be 4 hourly observations for a 12-hour period. A lot of women come in, deliver, and want to be as home as soon as possible if they've had, you know, a low risk labour and, you know, everything's gone to plan. They're in low risk settings. Even women in high risk settings, you know, we encourage them as health professionals to, you know, go home, and they want to. But it's important that women are aware that if we don't get the antibiotics in, that we would then want to do 12 hours of observations on the baby. And this is important for women to factor in other children, their families, the fact that they're going to be in hospital for that length of time, what that means for their discharge. So it's really important that all of these things are explained to women. Next slide, please. So the documentation, and this can be in electronic records or pregnancy handheld records, and at different trusts, the majority of trusts are using electronic records these days. So the woman has everything, all of her maternity records are held on their phones, and basically the download apps, and absolutely everything is on there. So the midwife publishes the, you know, all of the checks, everything that's done when they see them at the routine antenatal appointments, the scan appointments, obstetric appointments. So everything that, you know, can be in electronic records would have been in handheld records, but there are still some trusts who do have paper and you know, are continuing. So it's what midwives should be documenting, where they should be documenting it. Next slide, please. So all tests that are taken by midwives are the responsibility of the midwife to gain the results of the same. So at the booking appointment, community midwife will carry out a discussion about screening. And this will include the urine sample that's taken as baseline at the beginning of the pregnancy to rule out any infections that are underlying at the time. And then obviously throughout pregnancy, we take, you know, lots of, you know, there's blood tests, there's different screening tests, and whatever a midwife takes, it's her responsibility to then gain the results. Now, community midwives, there's continuity of care throughout many trusts. So it would be for that midwife to then spend some time in our clinic looking up the results of any tests that she's taken. So, and it's the same on maternity assessment units, excuse me, apart from on maternity assessment units, or if there's a team of midwives, then there has to be some kind of communication book that midwives will write that they have taken, you know, blood tests, urine sample, and the results need to be chased up and documented. These are documented in, you know, whether it's electronic or handheld written notes. They're documented in a section for the blood results and the urine results. There's also special features part, which used to be on the, or still is on the handheld notes, and it would be written. So if a woman was found to be Group B Strep positive, then this needs to be clearly documented in either the special features on the handheld records or in the risk factors on the electronic. So some electronic systems will have special features, but Group B Strep results should always go into the risk factors. Easily identifiable, midwives know that they need to look into these risk factors, and that's everything across the board, whether it's from blood results, urine results, scan results. So, midwives are fully aware that they need to be checking all of these things and checking that things have been documented. So the community midwife will document that the Group B Strep result is positive, and she'll do that, like I say, either in special features and or in the risk factors. And obviously, if the Group B Strep's been found to be positive within the urine sample at any time, whether it's booking or throughout the pregnancy, then it needs to be clearly documented when the test was taken, when the result was given, and when the antibiotics were given. And so just so that it's clearly documented, and then any subsequent midwives coming after that can see how it's been detected and what's been done. And then if there's been Group B Strep in previous pregnancy, this must also be clearly documented. Again, it's in special features or risk factors. Next slide, please. So what information does the intrapartum midwife require? So she needs to know, as in anything that we do when somebody comes in established labour, we look at blood results, we need to know the rhesus group of women, and if GBS has been found in the current pregnancy, then that will be found, like I say, in the special features, be documented in there, or it'll be documented in the risk factors. We'll also need to know if it's been found in previous pregnancy. Was the baby affected in the previous pregnancy? And we need to have a look through. So again, it's going to be either looking through the paper notes to see the discussions that have been held, or in the electronic notes, you can go through all of the clinical notes that the community midwives will document at every antenatal appointment, and see that the midwife has fully informed the woman regarding, firstly, a Group B Strep positive result, the options for intrapartum antibiotics, and if it's been on a urine sample, that again the antibiotics have been prescribed and given. So does the woman understand Group B Strep and early onset Group B Strep infection for the baby? This needs to be documented, and it needs to be documented in the clinical notes. And it needs to be clearly documented throughout the pregnancy that the discussion's been held and that the woman fully understands. And has she consented to have intrapartum antibiotics? Just because women are found to be Group B Strep positive, whether that be in previous pregnancy, current pregnancy, women have a choice, and not all women will consent to intrapartum antibiotics. If consent is not given, then it needs to be clearly documented, and it needs to be clearly documented that an explanation is being given and the implications for the baby. It needs to be documented that the midwife's explained that if she doesn't have intrapartum antibiotics, the observations that we would like to carry out on the baby following the delivery, and that needs to be consented to. And if the woman's consented to it, then it should be documented. If she's declined it, it should also be documented that she's declined to have intrapartum antibiotics and observations carried out on a baby. And midwives should be mindful that, these in-depth conversations are difficult, and it's difficult for women to take in all of this, which is again why it should be revisited throughout the pregnancy, just to ensure that women understand and that they're still happy to have intrapartum antibiotics and observations for the baby. Next slide, please. So the responsibilities of the midwife. So, like I said, midwives have a responsibility to ensure that all results are checked from the pregnancy at the onset of labour and pre-labour rupture of membranes. So we always check blood groups, and this is important, and any tests taken, so any urine samples that have been taken, all of this is fully accessible through the trust systems, whether it's e-record or whatever system any of the trusts have. Midwives always go on, have a look. We can see the scan reports, we can see all of the blood tests, urine tests, and Group B Strep status. And like I say, this should be carried out in line with normal practice to access results. And midwives should be mindful that it shouldn't be for a woman to come and tell them their story. So women can come in labour, and mostly do come in labour and are distressed. They're not going to be thinking about, you know, the past 9 months of everything that's gone on, and it's not their responsibility to tell us that, you know, they're Group B Strep positive in this current pregnancy, or the, you know, in a previous pregnancy, whether they understand it, whether they've consented to the intrapartum antibiotics, whether they've had antibiotics during pregnancy. So it's really important that midwives do look up all of these results at the onset of labour. Next slide, please. So field responsibilities of the midwife and the implications for women and their babies. And this should be outlined, and obviously this is something that midwives need to be really aware of, that a lack of understanding for a woman, if, you know, things aren't explained and she, you know, hasn't been, you know, kind of counselled to being Group B Strep positive, or if she was Group B Strep positive in a previous pregnancy, whether the baby was affected or not, and the implications for it all. It's a failure to allow women to make an informed choice, and women should be allowed to make informed choices for anything that we carry out, any procedures, you know, anything that would do with women. They have a right to agree to it or not. And the implications of not, you know, documenting that a woman is Group B Strep positive in the current pregnancy or has been in a previous pregnancy is that no antibiotics will be given. And whether that's through a swab being, you know, highlighting the Group B Strep, or whether it's, you know, a urine sample. And then no intrapartum antibiotics would be given throughout labour. And there would be no offer of immediate induction of labour if she came in with pre-labour spontaneous rupture of membranes, which would mean that a woman would be allowed to go home for 18 to 24 hours awaiting spontaneous labour, and she obviously should have been offered immediate induction and given intrapartum antibiotics. There would be no neonatal Group B Strep observations being carried out following delivery, and it's the implications for the baby becoming infected. And, you know, field responsibilities of a midwife, that is the ultimate, the thing that, you know, it's the implications for the baby. Next slide. That's my presentation. So obviously this is just from SOMEC for cases, and obviously midwifery experts that we have at SOMEC. Next slide, please. And just any questions, obviously I can answer questions at the Q&A session. And that's my presentation. Thank you all very much for listening.
Brilliant. Well, thank you very much, Julia, for that great presentation, and was really insightful. Just to introduce our next speaker, Myles Taylor. He's a consultant obstetrician and gynaecologist at Royal Devon and Exeter Foundation NHS Trust. Myles Taylor has held positions on consultant obstetrician and gynaecologist at the Royal Devon and Exeter since 2003. He has an active medico-legal practice spanning over 16 years. His particular area of expertise includes general obstetric, fetal medicine, multiple pregnancies, including twin-to-twin transfusion syndrome, intrapartum care, and general gynecology. And Myles is going to talk to us about an obstetric view on the key areas missed in GBS cases and signs to look out for during pregnancy.
Good afternoon, everybody, and I apologise I can't be with you live, but thank you to Richard and Alex and all of you for asking me to give you this overview on Group B Strep, and I hope to be with you at least to be able to answer any live questions afterwards. So let's proceed with what I'm hoping to get through in the next 15 or 20 minutes. So firstly, I'll be briefly discussing what actually is Group B Strep. This may have been covered in earlier talks. Try to put it in some sort of context, because in actual fact, although it's a huge issue in developed countries. It's actually far more so across the globe. And then talk you through the various options which are used across the world to try and prevent particularly early onset Group B Strep. And to look at a really remarkable example of successful litigation, and on the other hand, to look at the pathway of care, to look where potential pitfalls can occur, and how all of us in maternity should do our best to prevent these happening. So here is Group B Streptococcus. They tend to link up in little chains like that. They're present in the normal biome or flora of women, mainly in the bowel flora. It's the commonest cause of infection in the neonates and infants, a topic I'm sure that Janet Reddy will cover in great detail. We're talking about, in the average unit, say of 4,000, about only a handful of cases, thankfully, per year, so 0.4 cases per 1,000 live births. It is a significant cause of mortality, as I mentioned, but also, as you would expect, a significant cause of morbidity through sepsis. It can cause pneumonia, meningitis, and via the latter, brain damage. The lady who we have to thank for calling it Group B Strep, and I'm not a microbiologist, so I will only cover this in the lightest detail, was Rebecca Lancefield. She was in America, and she was a testament to putting up with a certain amount of misogyny and put her name to the Lancefield group. But perhaps she's less known for her recipe for eggnog. Now, as you know, eggnog, often drunk at Christmas time, not so much in the UK, but more so in America, uses raw egg. So, as you know, it's a lovely culture medium for salmonella. But if you use Rebecca Lancefield's eggnog recipe, you'll get away with it. So if you look really carefully, it's the massive amount of rum which effectively sterilizes any existing salmonella. So Lacial Nog is Rebecca Lancefield's not so well-known legacy. This is a really helpful overview of Group B Strep because it's not just about causing infant problems. So let's start on the left-hand side. And here's a mother. As we know, she often is colonized in about 25% of normal women, and most of the time it doesn't cause any harm at all. So there's that green arrow there. If the mother gets sepsis, then of course she could overcome that sepsis and retain her health. She could have injury herself, and she could indeed die, albeit rather rarely. We need to appreciate, of course, that it is a uncommon but recognized cause of particularly third trimester stillbirth. It is a cause and consequence of preterm delivery, and as you know, the ascending route from the genital tract can affect the baby, mainly during the process of labour, and if the baby catches or acquires Group B, may acquire it but not actually become infected. Otherwise, it could suffer from sepsis, pneumonia, meningitis, and neonatal death, or impairment. So this is the overall picture. So I said I put it into some kind of historical context. So these are the number of stillbirths in a given year. And so Europe and North America, so quite a wide area, you can see 700, but compare that, for example, to sub-Saharan Africa. You can see it is massively increased in that particular part of the world compared to Europe and North America. So this is a really important global problem. In the UK, you get an idea, 0.57 per thousand. It is a significant but relatively small problem compared to that. And the same thing is described in this diagram here. You can see the number of cases at the top there and the number of deaths below. And you can see here our own country doesn't even feature by comparison. Within our country, there is considerable heterogeneity. There really is a big difference between ethnic populations. So whites have a lower incidence of early onset disease, blacks, but the main group, for reasons which aren't really understood, are Asians, and in particular those from Bangladeshi origin. So if we're going to do something about it, we've got to try and provide high quality care to reach all women, in particular those of Asian origin, if we're going to make a difference. So how can we prevent it? Well, there are two methods. There is, well, the main treatment, if you like, or prevention method, and I'll show you how you get to that, is giving intrapartum antibiotic prophylaxis, IAP. And why? Because a Cochrane view has indicated that it actually works. So an 83% reduction. So legally, it's clear that on balance, if you should have given it and didn't, then you're going to reduce the incidence considerably. It's a very effective preventative tool. The key question, therefore, is who to give it. Do we give it to everybody? Well, most people would disagree with that, because plenty of people will carry the condition but don't, only 20%. So you'd be giving to far too many people. Only those people who screen positive, or only those with risk factors. This is the way the Americans do things, so screen everybody, and this is the way we do it in this country, and there continues to be considerable debate about which is the correct way to do things. So in a nutshell, the argument is universal screening, everybody in other words, or giving a risk-based protocol. So you ask a number of questions and see if the person is at risk, and if so, give intrapartum prophylaxis. So the Americans would say we should be doing it their way, and this is based in part on this evidence. This comes from the American College of O&G, who said that we should do this. And you can see once initial statements were released and guidelines provided, that the incidence per 1,000 births of both early and late onset disease plummeted. So you wonder why, therefore, we don't follow suit. But the RCG over the years has been adamant that we shouldn't do that, and these are the reasons given. So many women are carriers, the majority of babies not affected. First, and also late screening does not actually predict those who are going to be affected. Furthermore, no screening test is entirely accurate. And most babies severely affected are actually born preterm, so an entirely different strategy adopted is to give all women who go into preterm labour antibiotics as an alternative strategy. So we're trying to avoid nowadays, aren't we, to giving women unnecessary antibiotics. So that is the approach the RCG takes, and as a result, this is the 2017 pathway. So I'll just briefly take you through this. So let's start with the easiest one here. If you're pregnant and have, say, an elective cesarean section, or at least a cesarean section, even if you go into labour before the membranes are ruptured, then there's no need, even if you're a carrier, to give intrapartum antibiotics. In any index pregnancy, if you have bacteriuria, that's bacteria in your urine in that pregnancy, well, you can give antibiotics if it's proven infection, not just sort of colonization, and in any case offer intrapartum antibiotic prophylaxis. Now, if you're planning a delivery, I mentioned earlier, if you're going to preterm labour, offer this. And if you have a previous infant with invasive Group B, again, offer IAP. In a previous pregnancy, well, it's not necessarily the case that you will be affected in the same way in the index pregnancy, but you should offer it in any case. So at term, if you have preterm labours and you're a known Group B strep carrier, however it is detected, give it immediately and during any induction process, or as soon as is reasonably possible, and not to give it if there's unknown or negative GPS status. So I think I've covered all of those. But in a way, one of the points of this is that it is actually complicated. You can see for yourself that at many points along that the care might be suboptimal as things are overlooked. I'll give you a brief example of a case which I was involved with. This is a lady who was in her first pregnancy. She was in England and had uncomplicated care provided in the private sector. And this is important because in that sector, as you would expect, you can request things provided they're reasonable, then it's quite easy to access them. A completely different matter in the established sector. Anyway, she was, I think she was American and requested Group B strep screening. So the private obstetrician agreed and took a swab at about 35 weeks, and the swab result came back negative. At 40 weeks, so reached term without any problems, had a spontaneous vaginal delivery of a baby boy who was initially in really good condition, good weight, with normal APGAR scores. However, on day 3, baby sadly collapsed with Group B strep, sepsis and meningitis. Baby survived, but unfortunately survived with significant handicap, having a left hemiparesis, suffering a stroke, impaired vision and impaired cognitive and behavioural function. And the astute amongst you will recognise where the key suboptimal care was, and that is in providing screening, only an HVS was taken, and you will all know that if you're going to screen, you have to take a rectal swab. And the argument was that the yield, if a rectal swab had been taken, would have detected Group B strep even when the vaginal swab hadn't. So on balance, would have detected that she was a carrier. Mother would have had intrapartum prophylaxis, which, as I shown you earlier, would probably have prevented the baby becoming infected. So for the sake of a tiny wee swab, costing probably nothing actually, because you can use the same swab, but even if you use a separate one, probably less than 50 pence, the Medical Defence Unit had to pay out of the order of 15 to 20 million pounds. So that was one pitfall. I think if you are, the bottom line, if you're going to do screening, do it properly, and that includes taking the rectal swab, as I mentioned. Don't forget that you need to use a special enriched culture medium, otherwise it won't grow properly. I've been through the guidelines on who to offer intrapartum antibiotics, and you must give it correctly, this will be covered by Rennie, I'm sure, if baby sadly becomes infected, then to make a timely diagnosis. So in summary, the targets for intervention, a little recap, are either universal screening or identifying of the risk factors. Giving your intrapartum antibiotics results in infiltration of the amniotic fluid or by the antibiotics and can prevent the early onset disease. So what is the future of this? Because clearly it's a complicated business, and it's about time we resolved the key question of whether universal screening or giving just to target groups is the ideal way forward. And this trial, the Group B Strep 3 trial, is coming to fruition. As it's relatively uncommon in the UK, you need a heck of a lot of women to agree to take part, and the trial has done extremely well. It began to potentially stall, but the pandemic came upon us, and many hospitals were too concerned with recovering from that to take part in this. But I'm pleased to say that things are going well. The latest update, according to that website, which you can see, is that 71 hospitals are randomized, and they're going to be randomized to screening, universal screening, and also standard care. But they're also going to use point of care testing, which is, I think, probably one of the ways forward. So as soon as the mum comes in, then and there you can do a bedside test to see if she is colonized with Group B Strep, and if she is, then you can give intrapartum antibiotics. So they're going to end recruitment beginning of next year, and let's hope that this will answer that question. But perhaps a better solution to all of this is to have a vaccine. The Oxford Vaccination Group, world famous, of course, for their work in developing the COVID vaccine, but you will have heard no doubt about the recent development of a malaria vaccine as well. So it's not that they can't develop a Group B Strep vaccine, it's probably because their attention has been drawn to equally, if not even more important issues. And of course, the advantage, and they work out, sorry, before I go on, studies have shown that a vaccine given to pregnant women may prevent 250,000 baby and mother cases each year, which is quite a thought. Now, of course, the advantage of giving a vaccine, if it works, is it won't just protect the neonate, it will actually reduce that late onset stillbirth, which the condition can cause, and maternal disease as well. The problem with the vaccine is, of course, that you can take a horse to water and may not be able to force it to drink. There is considerable history in this regard. Diphtheria vaccine was shown to be successful in Canada, and it took many years before it was adopted in England. You will recall the fuss that followed the MMR vaccine when there was a hint that it might cause autism. Even the COVID vaccine wasn't terribly well taken up in pregnancy, even though people tried to reassure them that mothers that it was safe. So it's all very well having a vaccine. But anyway, just to let you know that there's this recent publication in the New England Journal in just July, so only a couple of weeks ago, has shown in a phase 2 trial that that this maternally administered vaccine can generate a really good immune response. So it won't be long now. I really think it won't be long now before a vaccine is available. So in conclusion, early onset Group B Strep is largely preventable. How best to target antibiotic prophylaxis has yet to be determined, and future studies are awaited to resolve this issue. But actually, I think the answer will be a vaccination which will reduce the morbidity and mortality of this disease considerably. So Thank you very much indeed for asking me. I look forward to answering questions in due course.
Brilliant. Thank you, Myles, so much for that. I think there was so much to take from that presentation, but I think one of the big things that I took from it is that crucial point that the cost of a test is so small, and sometimes in a lot of instances can be nothing at all, but yet the cost of not doing it can be so high, both economically and for the individuals involved. Moving now to Dr. Janet Rennie. Dr. Janet Rennie is a consultant neonatologist with a specialist interest in brain-injured babies. She was a lecturer in paediatrics at the University of Cambridge from 1985 to 1987 and held a consultant appointment in Cambridge until 1995. Whilst in Cambridge, she was also director of the medical studies of Girton College. Dr. Rennie held an appointment as a consultant in neonatal medicine at King's College Hospital in London from 1995 to 2004. She held a similar post at the University College of London Hospitals, where she was clinical lead in neonatology. Dr. Rennie retired from clinical work in December 2018, but continues to teach and conduct research. And Dr. Rennie is going to be speaking to us about the signs to look out for in a newborn and in neonates, including late onset GBS. So over to Dr. Rennie.
Thank you, Richard. Hopefully you can see the slides and screen sharing is in place. Let me know if not. It's a pleasure to take part in this seminar again, and it's great to see so much enthusiasm for this very, very important topic. As we've heard, the current statistics have shown that GBS is still with us, although there has been a very significant impact from intrapartum antibiotic prophylaxis. But we still need to be aware of the illness in babies, and I think actually awareness has fallen since the days when I started neonatology, when it was probably more common to see a baby with GBS sepsis early onset than it is now. So people don't always think of it when they should do, but we have got helpful, nice guidelines which I'm going to review together with a couple of example cases and hopefully address any questions. As we've heard, Group B Strep in the neonate has quite an interesting history, because it was very sporadic in the 1960s, but in the 70s, and by the time I started neonatology in the 80s, it had emerged to become the predominant cause of early onset sepsis in the newborn, and it remains right up there with E. coli as the big most common affecting organisms. There are many serotypes and the disease pattern shifts, and that has made vaccine development challenging, because a vaccine can be developed for one serotype and then another one emerges, and there are different serotypes in place in different countries around the world, and a vaccine has been talked about, as Myles said, for many, many years, ever since I was a junior. But it's very exciting to see that finally significant progress is being made in spite of the challenges about pattern shifts and different serotypes. The UK national study, I was part of this, aimed to determine the incidence of GBS at that time. It's now 20 years old, surprisingly, and to look at the serotypes and the mortality. And that showed, as we know, that there is a very clear bimodal distribution of cases. It's sometimes slightly artificial to talk about early and late onset GBS, but there is a clear peak in the very early days and then an ongoing trickle of what's called late onset disease, which was defined as up to 90 days of age. GBS typically causes septicemia plus or minus meningitis, but it can present with a focal infection, it can present with a boil, it can present with orchitis in boys, and osteomyelitis and septic arthritis occasionally are seen. In my clinical experience, they are very uncommon compared to pneumonia, septicemia and meningitis, but GBS can infect other organisms. As you've heard, and as you can see very clearly from the results of that national study, the vast majority of the cases present on the first day, very early in life. There is then an ongoing trickle of presentation of into late onset disease. Early onset was about 0.42 per 1,000 births, and late onset less common. When you added them all together, 0.24 per 1,000. Of the early onset cases, only just over half had a risk factor, which we'll talk about in a minute, but the known risk factors, prolonged membrane rupture and so forth. And that's important information when teaching paediatricians, because it isn't just babies who have had exposure to maternal pyrexia, prolonged rupture of membranes and so forth, who could develop significant early onset disease. Babies can just come along out of the blue without any prior warning, and that is crucial for recognition of illness in children. As we've said, the clinical presentation is dominated by early onset sepsis, signs of sepsis, which we'll address in a minute. Meningitis affects about 15% of early onset cases. It's more common in late onset, as you see here, shown in maroon. Pneumonia is very common because that's very often the way in for the organism, particularly via the infected liquor and then into the bloodstream. The septic arthritis, the skin infections and so forth are very rare in early onset and more common in late onset. But overall, there were only 13 cases who presented in a way that was not sepsis, 197 meningitis or pneumonia. As Myles has just shown, the impact of worldwide adoption of intrapartum antibiotic prophylaxis has been very exciting over my career in having such an impressive effect and reduction in early onset GBS, and his data went on longer, showing that those figures have held low since the adoption has continued. As we've heard, the current situation in the UK is a risk factor based approach, and that has its advantages and it has its drawbacks. If you do screen women, then you will pick up a percentage who are positive for GBS, but you can't rely on that staying stable, even if that screen is done quite close to birth. And other women will acquire it, and that leads to, in about 1,000 births, about 350 babies with early onset disease, of whom 10 will die. Unfortunately, some are left with a long-term disability. Many do get early treatment and recover. The BPSU study was repeated in 2014 to 15 and showed a slightly increased incidence compared to the 2000 and 2001 study. And again, only 36% instead of 58% had a risk factor. So the situation with regard to identification of the newborn has not really helped. We believe that the main pathway is, as you've heard from Myles, bacterial colonization, which then can invade the membranes, typically with ruptured membranes, but GBS can punch a hole in the membranes and invade the liquor even when the membranes are intact, and that way sets up a reaction in the placenta, and also the germs are breathed into the baby, who is making small respiratory efforts, practicing breathing with liquor and lung fluid. Of course, there's no air, but there are breathing movements, and the liquor is drawn in, and the organisms invade the lung. The baby gets pneumonia. The baby may be born at that point and present with pneumonia, or the process may continue so that the organisms enter the bloodstream and cause bacteremia, septicemia, and signs of sepsis, signs of septic shock sometimes, or just mottling and bloodstream infection. When the organisms reach a specific number per mil, they have the possibility of crossing the blood-brain barrier and causing meningitis. They also cause vasculitis, and that is the problem we're often faced with in medical legal practice with babies who have an adverse outcome. There is the argument that the process can be inhibited at various stages. Clearly, the most effective stage is to prevent transmission from the mother to the fetus in utero rather than intervening postnatally, but there are possible opportunities to inhibit the process between pneumonia and septicemia and meningitis. And many of the cases I'm involved in, which are numerous, I have to say, in GBS litigation, involve the arguments about that process, how long it takes, which is variable, and whether it can be affected. So the recognition of illness in the newborn, as we said, there isn't always a risk factor. And so all those who care for the newborn need to be aware of signs of illness in babies, which is difficult. Babies cannot talk to us. They can only let us know that they are ill by changing their behaviour. And I've put there, beware the quiet baby. The number of times I've heard, oh, my baby was a very good baby. And everybody said how good he was. Babies are not usually quiet all the time. Of course, they should be sleeping and waking. They should have cycles of sleep. When they're awake, they are usually consolable. It's usually possible to cuddle a baby, give the baby a feed, change the nappy. They should not remain inconsolable. So inconsolable crying is not normal behaviour for a baby. Neither is not waking up at all, not waking up for feeds. Because of the frequency of the lungs as the entry point, babies often present with respiratory signs. And babies should not make a humming noise, a grunting noise, a singing noise when they're breathing. That is abnormal. They make a sound which is because they are trying to expire against a partially closed glottis to maintain end FRC, functional residual capacity, lung volume. They breathe fast. The upper limit of normal is about 60, and they typically make a grunting sound, which once you've heard it, you never forget it. But if you haven't heard it, you don't always recognise it. And I've read in the notes the baby was singing, the baby was humming, and I think, oh, that is not right. Reduced feeding, dry nappies, abnormal tone, abnormal temperature. Babies typically become cool actually rather than hot when they're ill, and mottled skin. Those are all recognised signs which are highlighted in the GBS leaflet and are key in recognition of illness in the newborn. There's also an NHS leaflet about illness in newborn babies, which tends to focus more on jaundice, which is another bee in my bonnet, which is a lecture for another day. But gives ideas to mothers about how often the baby should be feeding and what the nappies should be like. They should become heavy and wet and frequent. The baby check system, I worked with Colin Morley for many years, and it's remarkable to think that there hasn't been another study of this type since the late 80s, early 90s, and there needs to be really. But this was a very thorough piece of research in which over 1,000 babies, some of whom were ill and some of whom were not ill, had information collected on their symptoms and signs. In other words, what the mother had seen is a symptom, and signs are things like mottling and temperature. And they were put into a massive computerized analysis, which was done by Tim Cole. And so the most important predictive symptoms were pulled out and developed a scorecard, which at the time was presented on paper. And I remember giving it to my girlfriends who were having babies in that era, and they loved it. And it had huge potential. It never caught the hearts and minds of the Royal College of Midwives because it involved the use of rectal temperature. And Colin, who is a man of his word, as it were, would never agree to change it. And so it fell under a bit of a cloud, which I think was a great pity. However, it is the only study of its type still that I have ever been able to find, and I did another literature search. This is the information from the original paper, which showed the p-values, in other words, the statistical importance of the most important signs that were then put into this scorecard. The NICE postnatal guideline was published in 2021, and in the chapter on scoring systems concluded that that was the only available evidence still. And the rectal temperature and axillary temperature are pretty close together. And the Lullaby Trust have picked up and used this scoring system with a switch from rectal temperature, but it keeps the same temperature cutoff as Baby Check did, which was rectal, which actually rectal temperature is a bit higher than axillary. It made a few other small changes, but again has been very popular, and I understand is about to be updated. The app, the Baby Check app, which comes on your phone if you download it from the Lullaby Trust, or you can use it in paper, allows mothers to score up the problems that they think their baby has. Is the baby being sick? How many wet nappies? Is there any blood? Is the baby drowsy, floppy, or looking pale? The features that we have just looked at as being crucial for determining sepsis. And the total score gives them a guideline as to what to do, either go straight to A&E, carry on observing the baby, or seek advice. So the Lullaby Trust Baby Check is designed for the iPhone. You can download it, score it up. There are some red flag signs at the beginning, and then you can score up the baby and decide what to do. It's free and it's proven quite popular. If the baby's in hospital and being observed by neonatal staff, they should be using the British Association of Perinatal Medicine track and trigger score. And again, I was on the working party who developed this. It was a lot of work to decide what was going to go on the chart and to decide the threshold of temperature, respiration and heart rate. It's color coded for ease of use, and so the midwife has a very helpful guideline as to actually what the normal range is in the newborn, which not everybody always has at the top of their minds, and they score up signs such as counting the respiratory rate, and if it's 60 it comes into the yellow section, if it's more than 80 it comes into the red section. And the score is totaled up in a similar way to the Lullaby Trust score, but this time based on physiological signs, and the midwife or carer in the hospital gets clear advice on what to do, either to repeat the investigations or to call for help. Some hospitals set up these charts on every newborn. Most do not. Most would start such a chart on a baby who had been exposed to something like prolonged membrane rupture, who wasn't on antibiotics, or a baby who was on antibiotics, who was still with the mother on the postnatal ward, just in case they deteriorated. So it has proven popular, and I think it is widely used, but it's not something that's done on every baby, and I don't think the midwifery staff would be able to cope with doing it on every baby in most hospitals. The NICE guideline is another important guideline to be aware of, in addition to the NEWT chart, and this provides clear information to healthcare workers on what to do in the situation of assumed neonatal infection. This also has a risk factor based approach with a red flag concept. It is like, as Myles said, with the IAP problem, the problem with all these guidelines is that if you're working on the floor in a hospital, you are sort of bombarded with lots of very complicated guidelines with complex algorithms, and it is hard for people to have it all in their head or to check it in every single case, and that is part of the problem. But there's no argument, I don't think, with the fact that these are important risk factors, which you've heard about before: prolonged membrane rupture, maternal interpartum fever, clinical diagnosis of chorioamnionitis, and then the baby factors: altered behaviour, altered tone, feeding problems, feed intolerance. These are all things that I've just talked about that are recognised, pulled out by Baby Check, and are unarguable, really, that these are potential factors. The concept of the neonatal infection guideline is if you have any of the red flag signs or two or more of the non-red flag signs, the baby should be treated with antibiotics. If there's only one risk factor, then the baby you should consider the situation, either give antibiotics, and if you don't, then you would definitely be using a NEWT chart and keeping a close eye on that baby with a low threshold to start antibiotics. The 2021 guideline recommended that the Kaiser Permanente sepsis calculator, which is an online calculator based on American insurance data, is an option. And certainly at UCLH, we did adopt that, and we did cut down use of antibiotics, because the downside of many of these guidelines is that you end up treating a lot of babies. If you're going to use the Kaiser Permanente calculator in your hospital, you need a fairly accurate figure for your local incidence of early onset sepsis. At UCLH, we use 0.5 per thousand. You need the gestational age. You need to know that maternal antepartum temperature, duration of rupture of membranes, and whether antibiotics were being given. And you can, I won't do it now, but you can try for yourselves logging on and getting advice from that as to whether you should give neonatal antibiotics or not. And it is helpful. So how about applying these guidelines, which we've all just heard, the Lullaby Trust, the Baby Check, the NICE guideline, how about applying these to a real case? Does it work? Well, here's a sort of example. Pyrexia 38 degrees for 40 minutes, a rising fetal heart rate on a partogram. And I've lost count of the number of cases I've done with that sort of sign, which isn't a well-recognised red flag. Maternal white count does go up in labour anyway, so can be tricky, but there were 92% neutrophils, baby born by failed Von-Teuse and a Neville, but successful Neville Barnes, reasonable Apgar scores, grunting at 20 minutes, and then sent to the ward and had a sort of borderline respiratory rate overnight. That baby probably should have had early antibiotics rather than waiting for the baby to deteriorate. Another case is a lady, unconfirmed membrane rupture, but a high vaginal swab, which, as you've heard, is not the optimal method for looking for GBS, did grow GBS, admitted in labour, and again developed a fetal tachycardia, a partogram showing a rising fetal heart rate, leading to normal delivery, baby again in reasonable condition with a degree of acidosis but not marked, who was admitted grunting and given cefotaxime, which isn't the best antibiotic for GBS, and later had a lumbar puncture done. 19 white cells in a neonatal specimen is too many, and the antibiotics were switched, but that did not prevent the baby developing post-meningitic hydrocephalus. So difficult cases very often. Again, a case highlighting failure of transfer of information. This is a mum who had an EDD at the end of August, and she had grown GBS in the urine, which, as you've heard again from Myles, is not an indication for treatment in the pregnancy, but it is an indication for intrapartum antibiotic prophylaxis. But this information wasn't transmitted to the GP, who really got the information of lead sample repeat. She was very anxious, this lady, because she'd had a previous neonatal death, and she was very anxious to be delivered. And she rebooked at another hospital, and the estimated date of delivery got shifted back to the end of July, and there wasn't communication between the two obstetric teams as to the original scan, which had dated the pregnancy pretty accurately to the end of August. Mother wanted an induction. She was very anxious for the baby to be born. She was in pain, and the team agreed to induce labour at what was thought to be term, but with the benefit of hindsight, was not term. And this is again baby born in good condition, but was thought to be singing. That is the urine specimen, which clearly grew GBS. So that was a failure of transfer. Baby was noted to be grunting, was heated up, still grunting. Sometime after birth was transferred to the NNU, but deteriorated and died. So a tragic, absolutely tragic outcome, leading to great sadness all round. If people had appreciated this baby, A, that mother had GBS, B, that the baby was actually significantly more preterm, then earlier intervention may have led to a different outcome here, because there was quite a delay in getting that baby to the baby unit and giving antibiotics. So it's still with us, GBS. It's still coming along in babies who weren't identified as having risk factors, and a baby who is on a postnatal ward or at home who has concerns raised needs a proper assessment, a proper examination and check of clinical signs. It's still the case that the commonest and most concerning clinical signs are respiratory. Years and years ago, Bernie Bauman said we could predict them all by counting the respiratory rate on every baby. And I don't think he's completely right, but he wasn't far wrong. Temperature instability, going off feeds, dry nappies, just not right. And a good neonatal nurse will spot that. But young mothers who haven't had babies before may not know the importance of these early signs, and education is crucial. There is naturally concern about GBS, and it does lead to large numbers of babies receiving antibiotics, particularly on postnatal wards, because of concern. And that's appropriate, but it's also a problem in that that is invasive. It means the mothers have got to stay in hospital unless there's a very good system, which few places have, for home antibiotics. And in our own hospital, we did an audit over 2 months, and not one of these babies actually had GBS, but 75 were given antibiotics in 2 months. So it's a big problem, not only for the mother possibly having IAP when she doesn't need it, but also for the baby getting antibiotics when they don't need it. It's very crucial to get the balance right, and we're still working on it. So thank you very much for your attention, and hopefully we can have some questions later on.
Brilliant. Thank you very much, Janet. I think the most I took a hell of a lot from that talk. It was fascinating, but I think one of the most really important points was that point about be aware of the good baby. And I feel as if that's something that you kind of need pinned for every single new mother to hear, because I just feel that that is such an important statement. And you do often hear so many times our parents, when they call us, saying, I thought I had the perfect baby. Thanks very much, Janet. We've got quite a lot of questions coming through, but I don't want to stop people sending them through, so please continue to do so. We will try and address them all today, but as I say before, please put your email address and name with the question so that we can respond. If we don't respond today, I know our panel of experts are more than happy to send answers after today. Our next speaker is, in fact, a client of Erwin Mitchell. I'm not going to give really much more introduction because I think she does it all for herself. But this is Danielle, and this is her telling her story.
Good afternoon. Sorry, first of all, that I can't be there today. Timing's just not great with picking up Aurelia from school. So my name is Danielle, and I just wanted to tell you guys today a little bit about my pregnancy with Aurelia and her birth. Now, my pregnancy was perfect. Everything was great, no concerns at all. I went into out of hours at about, I think, 34 weeks with what they did say was Braxton Hicks, and they diagnosed me then with high blood pressure and said that unfortunately I wouldn't be able to go back to work, so I took maternity leave early. During that appointment also, they did a high vaginal swab. That swab was then sent off, and I heard nothing back about that. Everything seemed fine. I was on medication to just reduce the blood pressure, and at 39 weeks and 4 days, I went into labour with Aurelia at 5 AM. Wasn't quite sure what was going on. It was a strange time. He was my first child, so I just got on with my day. Got to about 9 o'clock when I thought, actually, look, this is happening. Myself and my partner at the time, Aurelia's father, phoned into the hospital a few times, and we waited long, we waited until probably about 1:30 that day when we phoned them and they said to come on in. By the time I got into the hospital, I couldn't really walk. It was extremely painful, and it kind of all is a little bit of a blur, but things I do remember are that my waters broke while I was there, and there was a lot of meconium, of which I was told, oh, it's normal, that's fine. Yeah, sorry, it's a bit crazy when you think back now. So they gave me some pads, and obviously things just seemed to be progressing. They didn't seem to be concerned about that at all. A little bit later on in the day, I was told that I was I think 10 centimeters dilated, and I kept telling them that I needed to push, and they told me I couldn't. By the time I could push, I was pushing for a good while and nothing was happening. Just gas and air, I'm proud of myself for that. Obviously, eventually we did go stronger, but yeah, so they told me that obviously monitoring Aurelia's heartbeat, that when I was pushing, her heart rate was dropping. And then from then on, it was a bit crazy. I think the time just flew by. By that point, it was probably around, I don't know, 7:30, 8 o'clock, when they said I needed to go to theatre, and they needed to help get Aurelia out. We were told that the theatre room was full and that we had to wait until it became available. And it still makes me chuckle to this day. They said I could keep pushing if I wanted to. Obviously, pushing isn't going to get her out. So by that point, they gave me some diamorphine, cyclizine. Obviously, the pain was quite bad. I then remember them taking me down to theatre, and they gave me a spinal. I don't remember much about what the doctors said, just from experience, from what I can remember. And it was that there is a funny part I probably should tell you, because it wasn't all bad. It wasn't bad at all, really, just things happened. They said they needed to help get Aurelia out with some forceps. So they did an episiotomy. But before they put my legs up, and I wasn't quite sure whose foot was by my ear, because I didn't think my legs would go that far, but they did an episiotomy to get Aurelia's head out. I mean, the tugging was unreal. They were pulling Aurelia whilst pulling me down the bed, and someone was holding me at the other end to stop me coming down the bed. They did get Aurelia's head out, and the cord was wrapped around her neck, so they took that off. They then struggled to get Aurelia's shoulders out, which they did by some force. I mean, I think she wasn't breathing when she came out, but it didn't take long for her to get that back. And then they said she was absolutely fine. So I breastfed her down to recovery. Things were brilliant. Obviously, new mum, everything's a bit scary. Anyway, so I then, went throughout the night, and then, so I had her at about 11 minutes past 10 on Saturday, the 12th of September. And come about 3 a.m, Aurelia's father left, and I struggled to settle Aurelia at all. I couldn't get her to feed, couldn't get her to settle. whilst I appreciate new babies don't sleep, Aurelia didn't sleep at all. I couldn't settle her. So 6 a.m. I phoned Aurelia's father and I was like, look, you need to come back. I can't do it. I can't settle her. I can't get her to sleep. The nurses came in and out and I said, look, something's not right. She's not settling. I can't seem to do anything. And I couldn't get her to feed. I couldn't get her to latch on. So eventually they came in and they told me I needed to express 1 ml of milk into the world's tiniest syringe. I had no idea what I was doing. Someone had to come and show me how to do that. And still Aurelia wouldn't take it. This went on throughout the day. They came in, took some observations. From what I can remember, they just wrote them on slips of paper and put them in their pockets. She had dark poo all day. I get that that's normal, but she just was not sleeping. She wouldn't settle, she wouldn't feed. I think it got to about 8 p.m. on the Sunday, and they did the midwife handover, and the midwife came in and she basically said, right, she's grey, Aurelia is grunting, she's not happy with how she's presenting, and that they would get paediatrics to come and check her over. They came back and they checked her over and they said, we're going to take her down to NICU to, just do some obs, make sure she's okay. I mean, I give it 30 seconds and they were back. And they took Aurelia and I didn't see her then for 2 hours. When I finally got to see Aurelia, she was, she was in intensive care down in NICU on life support, sedated. And I remember that the first thing they said was that she was very, very poorly, and not to be mistaken by the fact that she looked like the healthiest baby in there. They mentioned the word meningitis, and instantly you think, good God, she's going to lose her arms and legs, They said as soon as she got into the lift to go down to NICU, she started seizuring. They couldn't stop those seizures, no matter how hard they tried. The next day, they called the nest team from Bristol, who came to take Aurelia to St. Michael's. They struggled to stabilise Aurelia, and they said that they were going to need to blue light her down to Bristol, and that myself and Aurelia's father couldn't go with them because it would mean one less doctor. At this point, they didn't even know if she'd make it there. So we drove to Bristol, and we got to Bristol where she could receive the treatment that Gloucester couldn't give. She was there for cooling. She was on life support, and this was the Sunday. They took her for an MRI, and we didn't get any results, and there was no improvement by Friday. And I can remember this day like it was yesterday, when they called us into a room and said that they did the MRI and they weren't quite sure how to explain to us the severity of Aurelia's condition. They had sought second and third opinions from Great Ormond Street in London and a children's hospital in Toronto. And it was then that we were told that if we didn't make the decision about what was best for Aurelia, if she didn't improve, then they would make that for us. That if Aurelia survived, she would have no quality of life. She'd have no normal friends. She wouldn't go to any normal school. And to think about what kind of life she would have. That very same day, we had family come and see her. My parents literally flew out to Morocco on Saturday, and they were back by by the Tuesday. They all came to see Aurelia, and I'm crying, but it's not all bad. We gave Aurelia a cuddle, and she started making these funny noises, and I was like, she's choking, and they told me that it wasn't possible. Now, I remember it was like a movie. You see it in the movies and you think that's never going to happen to me. Aurelia, she was choking, so they popped her on the table, the buzzers went off, the alarms went off. There were hundreds of, lots of people come running in, and they said, we're going to take the tube out and see what happens. Now, Aurelia breathed by herself, and then she went blue, and I thought this was it. Within a couple of days, she was on CPAP and high flow, and she improved from there. They had absolutely no idea how this was happening. They said she wasn't a textbook child, and it was, you know, the care that they gave to Aurelia in Gloucester and Bristol was second to none, and I cannot fault that. It was 4 weeks later, Aurelia was taken back to Gloucester, and a week after being back there, we were going home. Aurelia was diagnosed very early on with Group B Strep, meningitis, septicemia and pneumonia, and they told me that she had cerebral palsy and that she would never walk. Very unlikely. Now, I didn't realise when they give you that diagnosis the impact that that actually has, not just on my life, but her life. She does go to a special school, but her quality of life is incredible. My little girl may never walk, but, and forgive me for saying it, but she brings more joy to my life than I can imagine any other child. She is incredible. She, every single day, she does her best. She doesn't let it bother her. She is just an outstanding young lady. She's 6 now. This was, and sometimes you say it's a very long time ago, but for sometimes when I think about it, it was just yesterday. I can't fault the NHS at all. The only thing I would say is that testing me for Group B Strep, just that one test that you actually did do could have made a huge difference to Aurelia's life. She may not have the disabilities and the struggles that she deals with daily, despite being so happy, had this just been relayed. Lots of people say, we didn't get tested for it, they didn't offer us the test. In our case, we had that test. The results were there in black and white. They just weren't shared with anybody. So I would say, and I always say to people about Group B Strep, and that is that it isn't known enough. Had those results just been put in my notes, had they known that I had Strep B, they could have given me the medication and Aurelia would have been fine.
There is nothing more compelling than hearing the words of a mum telling her story, and more importantly also saying how easy something could have been avoided if things were done correctly. And I think that's the real focus of today, because there are so many learning points, and everybody involved in cases or in healthcare never wants a mistake to happen, and we want to do all we can to make sure they don't happen in the future, which I think nicely, in essence, leads on to the question and answer part and the first question and answer part of today. So thank you, everybody who sent in those questions. But as I say, please feel free to send them in, because we have another one later on this afternoon, but also we can address them after the conference today as well. The first question, I imagine, is a talk in itself, and I know I'm going to pick up on it briefly when I reflect on things later on this afternoon. But I think the first question for Julia that came in is, I'm interested in record keeping and what information it is useful to have recorded in such cases. The only comment I would make before I hand over the question, and I know I will cover this a little bit later, is from a legal perspective, if it's not recorded, then the general consensus is it didn't happen. And so the point I would make as a lawyer, not as a medic, is to say, put it down, because putting it down means you can, years down the line, explain what did happen, as opposed to not putting it down and saying it happened, but it wasn't in the records. But that's enough from me, and I'll hand over to Julia, who will probably give a much better answer.
Thanks, Richard. In terms of antenatal care, everything, absolutely everything, from the tests that we take, so from your first line urine sample that you take, and then obviously at 16 weeks when you bring the woman back, you are checking all of the results, and all of these results should be checked with the woman and documented clearly. So that doesn't matter whether it's electronic or whether it is paper copies, the results need to be documented. And then obviously what's going to happen. So the plan, so obviously if it's picked up on the urine sample early on, then the plan's going to be for, you know, a message to be sent to the GP to then prescribe antibiotics straight away. And then it's all discussions. So it's discussions about planned intrapartum antibiotics, the understanding that a woman has, how the antibiotics are given, you know, over what time scales they're going to be given. Does she understand? Does she consent? If it's a previous pregnancy, then that should be clearly documented. And again, documentation surrounding the discussion that's been had. So discussion about whether the previous baby was infected with GBS. If so, then obviously intrapartum antibiotics. If not, you know, you can discuss with the woman that, you know, she does have a choice, but we can also offer a specific swab between 35 and 37 weeks, which will then tell us whether this current pregnancy is positive or negative. But regardless, you know, even if she's negative, then again, document it, but document the fact that you have said, you know, you're negative in this pregnancy, positive in a previous, but, you know, you will be offered intrapartum antibiotics. So the short answer is everything that, as Richard says, I think it's a standard practice, definitely in midwifery. You know, if you don't write it down, then it never happened. And I'm sure, you know, at times midwives will say, you know, I offered somebody a cup of tea, I better write it down. And, you know, it goes from, you know, things like that to the most important things. And these things, you know, in practice will save lives. It will, you know, help a really broad understanding for women. So absolutely everything, and whether you know, document that in the special features, but also in your risk categories of however your notes are, whether they're electronic or paper.
Brilliant, thank you, Julia. I think the next question somewhat forms both to you, Julia, who can speak from being on the ward, and I know, Jane, you can add to this about what's being done to help. And perhaps we may pick up on it a bit later with Myles Taylor when he joins, and also with our other experts. But how is language a barrier, and does it have a contributing factor, and what can be done to kind of get over that?
Yeah, I think that it's a contributing factor if it you know, if it's allowed to be, if you like. You know, there's so much these days in terms of, you know, once upon a time you used to have to get an interpreter to come in, you know, in person, you know, that they're just a telephone call away. As we know, we shouldn't use family members, but, you know, we can ring, you know, the helpline, get the specific interpreter, and explain absolutely everything. Any leaflets that are being given, you know, sometimes the trusts, and I know from my own experience, it's, you know, can be difficult to get them in every language, but the internet is a fantastic tool in that, you know, you can get practically anything in any language. So I think it's only a, you know, it only contributes if midwives don't take the time to ensure that, you know, an interpreter is used, and it's absolutely mandatory that women have interpreters throughout antenatal, intrapartum. No, you know, no woman should feel like she's missed out just because she can't speak English. So yes and no, it can be, but it shouldn't be.
And to you, Jane, just to add on from your perspective.
Yeah, from my perspective, I mean, languages is of course about, you know, different languages, and we at Group B Strep Support worked with the Royal College of Obstetricians and Gynaecologists on a joint leaflet about Group B Strep that came out of their 2017 guidelines. And thanks to a grant from the National Lottery, we were able to translate that joint leaflet from English into 14 additional languages. And that is free to download from our website, so hopefully that link can be shared. So it's not every language, but it is 14 additional languages as well as English. I absolutely agree with everything that Julia said about, you know, it is important that we make sure that translations are available. But it's not only about translations, it's also about using language that is individual centred. So making sure that the language we use in any situation is understandable by the pregnant woman or person or new parent or carer, and acceptable to them. So language is just like a whole day's seminar, Richard, not just 2 minutes. So I'll stop there.
I feel most of these questions you're going to be asking now are going to be filling up on seminars in themselves. But just to follow up just very briefly, Jane, on that, in terms of the leaflet, we'll obviously at the end of the presentation make sure all the delegates get access to the leaflets and the links to them. But the question from that is, when should these leaflets be given to people? Should they be given to people when they, you know, we've got a lot of midwives I know attending the conference today. It's at what point should this be discussed, and should this be added and be given to them?
Well, the recommendation from the Royal College of Obstetricians and Gynaecologists is that all pregnant women should be provided with an information leaflet about Group B Strep as a routine part of antenatal care, which is how the leaflet came about. Because, you know, if you're going to make a recommendation that a leaflet should be given, then there really needs to be a leaflet to give. So I think, you know, it needs to be given antenatally. In terms of pregnant women and people being able to make an informed choice about what they want to do, you know, whether they want to test, if they're eligible for a test within the guidelines, or whether they want to test outside of the guidelines, if they want to do that privately, if they're going to be able to make that decision in time to have the test in the Group B Strep testing window of 35 to 37 weeks of pregnancy, then probably you need to be giving the information leaflet maybe somewhere between 24 and 32 weeks of pregnancy, and that gives people time to read them, talk about it with their friends and their family if they want to, talk about it with their midwife so that they can come to a decision that's right for them. We know that there are quite a few hospitals that just give this and goodness knows how many additional leaflets out at booking. And for some people that would be great because they'll sit and the
say,
leaflet reading public, love it, but that doesn't work for everyone. So and again, it's as Julia was saying earlier, it's not just about telling people once, it's making sure that they have the opportunity to talk about Group B Strep, to ask their questions about Group B Strep, rather than just doing it, once and done.
Brilliant. And okay, so I think the next question is probably for Janet, but Myles, you may want to add to it. Will a baby be covered by intrapartum antibiotics, even if the woman only has received 1 dose?
Yeah, I mean, it's a very good question, and we do have research on that, and we pretty well know. Again, when we started out with IAP, it was said that you had to have it 6 hours before you were born for it to be effective. That came down to 4. But that's about where it sits. So as a neonatologist, I would say that obviously we would like people to have had the whole 3 grams of IV penicillin 12 hours before and then a follow-up dose. But if 1 dose has been given more than 4 hours before the baby's born and the baby's well, then the baby can just be observed and will be fine, doesn't need treatment. If a baby is had IAP 2 hours before, then I would be a lot more nervous, and I think a lot of neonatologists would screen and treat that baby. Some might say, well, if the baby's entirely well, we can put the baby on a NEWT chart and keep a close eye and just have a low threshold. But I don't think there's any scientific evidence that 2 hours is good enough, whereas I think there is for 4 hours. I'm happy to be corrected by anybody who has anything better up their sleeves, but that's where I would be. So yes, and that is one of the problems, that if people come in and labour and deliver very quickly, even if they've been flagged up as needing IAP, there isn't always time for them to have it in time for it to be effective, and that's one of the sort of failings of it.
Brilliant, thank you. I think this one is probably actually for Myles to start with, but it may be one that Janet and Jane, you may want to feed into. To screen effectively, do you need a high vaginal swab as well as a rectal swab? Should you also have a urine sample screened? What is considered a correct cultural medium?
Well, my understanding is that you need the vaginal swab and the rectal swab, and that you need an enriched culture medium. I'm not sure you need to do anything else. That is the established thing. I guess you can understand why, because it comes from the rectum and then goes elsewhere and then perhaps get into the urine. So I suppose it's a bit of a waste of time checking in the urine, because it's almost certainly going to be in the bowel if it is in the urine. Yeah. So the other thing about the previous question, I think I agree entirely with what Janet was saying, but it highlights the importance of communication between usually the midwife and the neonatologist, because let's face it, if baby looks okay, the neonatologist may not get anywhere near the baby in a timely manner, unless you say, well, I've only had a couple of hours of treatment and the baby's at risk, And so I think everybody needs to be the advocate of your child and to suggest that the baby's looked after in the proper way that Janet outlined. Was there another question there, Richard, or was there? Well, have I dealt with that now?
I feel you've dealt with it, but it probably leads into my follow-up question, which again then I'll hand to Janet if there's anything to add into, which was, what are your thoughts about rapid testing at bedside to reduce overuse of antibiotics?
My thought is, I think it's great. I suspect that, like everything else in life, it will have limitations. It might not be as good as the standard testing, but the Group B Strep 3 trial should be able to answer this for us. So I think it's the way it's going, to be honest.
Brilliant. And on that, Janet and Jane, anything you would like to add? Perhaps I'll go to Jane first, just in case, and then I'll hand to Jane. Did I say Jane? I think I may have said Jane twice, didn't I? Let's go to Jane first.
I don't think we need two of me, Richard. That would be at least one too many. Yeah. So yes, absolutely. You know, coming back, completely agree with what Myles said. You know, we're talking a low vaginal and a rectal swab, and it's important that it's both of those. And it's certainly not just a high vaginal swab, and actually we shouldn't be taking high vaginal swabs for Group B Strep at all, because that's not where you're going to find it. You're going to find it in the rectum and the low vagina, and actually the sample taking is likely to be the same regardless of whether it's the enriched culture medium test that's done antenatally at 35 to 37 weeks, and then Group B Strep can be quite difficult to grow. Other pathogens that live quite normally and naturally in the vagina and the rectum can sort of overgrow it, which is why you need that extra enrichment step, so that takes a little bit more time to grow. But the swabs would be the same with intrapartum testing, a low vaginal and a rectal swab. And Myles is absolutely right. The GBS3 trial should answer the question, not only the question of is a risk factor approach better than a testing approach for the UK at reducing early onset Group B Strep infections in babies, but also if testing is better, then is antenatal testing at 35 to 37 weeks using culture or intrapartum testing using PCR a better approach? Yeah, I, like many, are waiting with interest to see what those results are.
Brilliant. Thanks, Jane. Janet, anything you would like to add to that, or I will jump straight?
I agree with all that. I mean, I think we're all anxiously waiting, because it would be good to cut down the number of babies who are on IV, because you have to give it IV. They don't absorb penicillin orally, and the days of giving IM injections to babies went out in the Second World War. I mean, we just don't give IM injections. They're painful and they got muscle contraction, so they have to have a cannula in, and that's a problem. I mean, they fall out, they've got to be recited. You know, you don't want your baby to have to be cuddling the baby with a cannula if the baby doesn't need antibiotics, and it changes gut flora permanently and all the rest of it. So it is all about preventing the terrible stories that we have heard, and yet preserving as many the mother-baby relationship without intervention as much as we can, and that is a very difficult balance in neonatology.
And also in the mother as well, because IV antibiotics with the pain, and in some units it can convert you from being low to high risk, which is
the odd, and still the odd anaphylaxis. Yeah, not many, but yeah.
I feel my next question, which we'll start with Janet, is, well, it's going to be a combination of two together, because I think they're two very important questions. But again, I think you'll both react to it in the sense of saying, or you'll all react that this is a day's presentation in itself, which is the question. I think it's phrased as, why in some cases does strep B affect and can cause death of unborn healthy children? I think the question in itself is, why do some people get it, some people don't, even if, you know, a mother may get it in one pregnancy and not another?
I think the question as to why some babies go on and die, whereas others don't, it is a complex interaction of when did they get it, the load, the bacterial load, and above all, the antibodies. I mean, that's why lots of babies don't get it, and that, of course, is the drive behind the vaccines. If we can vaccinate them against all the serotypes, then they won't get ill. And a baby who gets invasive disease, a mother doesn't have good antibody levels. That's why we make such a fuss about treating the next baby of a mother whose previous baby had it, because we know she hasn't got any antibodies, or else that baby wouldn't have got it. So the babies who deteriorate and die very quickly they've probably received a big bacterial load. There may be some genetic factors behind their immunity, plus they haven't got good levels of antibodies. That explains the different pattern of neonatal clinical presentation.
And I guess the question that followed in that flows from that is that I understand that GBS can be found in the gut flora, but how does it get there? Should we be giving women basic precautions to take in the same way we talk about foods to avoid? I guess the question is can we do anything other than a vaccine to prevent?
I mean, I'm not a microbiologist. We haven't got a microbiologist on the panel. If we do this again, perhaps we should have. But I'm not aware of. It's not like listeria. You know, where you shouldn't eat unpasteurized cheese, and it's not like fish and things. I've never heard that there's any particular food, or you know, I think it's just there in the environment, and you perhaps get it on your hands and ingest it, and it stays in your gut and colonizes and lives in the gut. But I'm not a microbiologist, but I'm not conscious of. I see Myles is nodding. I don't think there's any dietary advice that can be offered.
No, I would agree with that, and thank goodness so. Could get enough dietary advice already.
Especially if you're pregnant, yeah.
Yes, exactly.
Okay, so the next question we have is the recommendation from NICE that hospitals can use either their risk factor approach or the Kaiser, and I'm probably going to pronounce this wrong, permanent calculator.
I think it's Permanente, isn't it?
Permanente calculator equally, or do they give a preference?
You're supposed to have, as James pointed out, you're supposed to have audit in place, and we did have audit in place when we introduced it. So if you're going to introduce it, you need to have an audit cycle. You can't, you know, they didn't absolutely give you just a straight choice, but Jane probably knows more.
Thank you, and absolutely, Janet. And I would have known that you would have, your trust would have implemented it appropriately. I should probably flag that I was a member of the guideline development group for that. So yes, I know a little bit about it. And the recommendation was very clear that actually the NICE risk factors approach was recommended, but being alive to the number of trusts that had already implemented or were considering implementing the Kaiser Permanente sepsis calculator, there was a recommendation that if you are going to use Kaiser Permanente, or KP, it's a lot easier to pronounce, then that should be in the context of a prospective audit. And Janet listed, I think, all the the key auditable items, the data items that needed to be collected.
And there's always a worry, isn't there, Jane, that algorithm is hidden from us. You know, the calculations behind it are hidden from us, and you know, how often are they going to update it? And if you go on, you know, it's not UK data, it never was.
No, and it is different. I mean, it was developed from the US, in the US, and you know,
very
great
model, yeah.
Very different model. In the US, there's routine testing for Group B Strep, so you know they know what the Group B Strep carriage rates are. Group B Strep infection in babies is a notifiable disease in the way that it's not here in the UK. So it's not the same. So I was very pleased that the context was put. If you're doing it, you make sure you audit it and audit it thoroughly.
And it may get increasingly dated. I think that's the
Brilliant, thank you. So my final question before we move to a break for everybody, and I feel this is one where I'll start with the medics and then I'll move on to Jane to give her perspective on what else can be done. And that is the question, I guess, for the medics in the first part, is where you have a patient who is asking for a test but doesn't necessarily meet the criteria. What is and what I mean by the criteria is that they say to you they're concerned about GBS in pregnancy, but they don't have any history of GBS. Are they entitled to a test? And I asked that to Myles and Julia, and then my question that follows on to Jane is, where can they get it if they can't get it from the NHS? Is there the possibility? What is the recommended test? Is that something you guys would be able to answer?
Well, it extends to all sorts of weird things that people ask for, and isn't so weird really. The question, and you know, for example, people request cesarean sections for non-medical reasons, and NICE has supported that. Jane will tell us whether NICE have commented on this specific issue. I bet they haven't. I guess the question boils down to who's going to pay for it, because if it isn't backed by NICE, then the trust has certain justification for saying, well, you know, we've got a limited amount of money, we're not going to pay for it. The joy of this is it actually probably doesn't cost very much money at all. So in practice, and you didn't hear this here, rather than spend an hour trying to dissuade this person that it doesn't meet NICE guidance, I would say, all right, then we'll do the test. But the caveat is that we're not used to doing them. So there is a make sure that it's done properly with, you know, rectal swabs and enriched medium and so on. Otherwise, you could be in a right pickle. But fortunately, I don't face this issue very often.
And my one question to follow up on that before I hand over to Jane, and that is just to say, when should the test be done? Because I've often heard people say, well, we've done it here, but it was when is the, if they're going to do a test, when should it be done? When is the appropriate time to do it?
Well, I would look it up and do it as near to the likely time she is going to go for vaginal delivery as is feasible. So you don't want it too late because you won't get the result. And you don't want it too late, she might go into labour without the result, then what you do. But I guess about 36 weeks. But that, as again, this is the American way of doing things.
And Jane, then I think that nicely hands over to you. I'm sure you often get it through your charity, people approaching you and saying, where can I get it from privately? And obviously it's making sure they do get the right test. So what is the advice the charity gives from that perspective?
Very similar to what Myles said, that, you know, ask your hospital, because there are certain situations in which you should be offered the opportunity of a Group B Strep specific test, the ECM test, you know, the low vaginal rectal swab, cultured using enrichment culture in the laboratory. But not all NHS trusts have that test available for them to offer. So please, you know, if somebody is getting I was going to say a backhanded test, that's not quite the right language, but you know what I mean. But if they are getting a test that isn't sort of standard within the NHS, then make sure it's the right one, because if you're just having an HVS, then there's a significant risk that even if you're carrying Group B Strep when the swabs are taken, you will get a falsely negative result. Up to 50% of standard HVSs that are then just put on an agar plate will come back negative, even though mum is actually carrying Group B Strep. And of course, sort of, you know, that way lies madness. At the moment, the current recommendations by the RCOG are is that maternal request isn't a reason to be provided with an ECM test, which seems a bit daft, given, as Myles pointed out, you can ask for a cesarean, and you know that is supported. We do list on our website, and we have, you know, quite stringent regulations about who we will list on our website. But we do list on our website organisations that we know offer ECM tests following the what was Public Health England and is now UXA, British Standard Operating Procedures for Group B Strep, and then so that people can do it privately. They can do the tests at home. Research has shown that taking the swab samples yourself are just as reliable as your health professionals doing it for you, and they cost under £40 to do.
Brilliant, thank you. I think that's where we will probably draw it to a line for now. So we now move on to myself. So just to introduce myself, I'm a partner within Irwin Mitchell London office. Irwin Mitchell deal with clinical negligence cases nationally. We have offices throughout the UK, and we are rated Tier 1 within the Legal 500 for clinical negligence cases. Within our London office alone, unfortunately, we deal with approximately 40 to 50 birth injury cases being investigated at any one point. If we move on to the first slide within my presentation, I'm not sure if it's moving across or if perfect, great. The purpose of this talk is going to be in two parts. But firstly, I'm just going to briefly touch on the medical record side of things, just going over what Julia had mentioned earlier, just with some key points from a legal perspective. And then I'm going to talk about a couple of case studies. So if we move on to the next two slides, if we skip the next one, but move on to the one after. So I just want to briefly touch on medical records, because these are things that we see from a legal perspective all the time. And I think it's quite worth just highlighting from that point of view of what differences can be done, which can alter the situation. So firstly, and I think sometimes these do sound obvious, but when I come to talk very briefly about case studies in a moment, you'll understand why. Read patient history. We regularly see in instances where the information is written within a patient's notes, but no one has provided it in a handover and no one is taking the time to review the available notes. In terms of Group B Strep, this can regularly cause issues where Group B Strep has been identified in a previous pregnancy or in a test result in the pregnancy and has returned a Group B Strep positive result. This information obviously can influence clinical decisions. And you heard from Daniela earlier that it's not sometimes about whether you do the test. Actually, sometimes it's about realising the tests that have been done. And having represented a number of families in various different serious brain injury cases, it is often the case that the information that was needed was within the medical records. But unfortunately, due to the fact of seeing different people, that information either wasn't handed over or the individual unfortunately didn't go back and review the records. And I think one thing we say as lawyers is you can never have too much information, but it's what you do with it, which is so important. The next thing is about updating records, if that wasn't obvious enough, is to make sure you always have an update of the patient records. However, it's more to reinforce that when it comes to solicitors considering medical records, often years down the line, then if it's not recorded within the notes, then in essence, it didn't happen. And I think that's what we mentioned very earlier on when that question came in about what to record in the records. And you may have seen from the other experts nodding in the background that the fundamental point is sometimes when people are re-looking at events that happened, it can be 4, 5, 6, sometimes 10 years later down the line. And obviously healthcare professionals see numerous patients every day, so they may not always remember what did happen at that one appointment. So if in doubt, put it in the record. Clarity. The next point is all about clarity. Updating records is of course key, but providing clarity of the records and making sure the notes are clear is very important. Clearly set out your assessment, your plans, but also the timing of those events. Some cases can come down to minutes rather than hours. Briefly set out why you're considering something, if it's outside normal practice, or even where it is. One of the things to say, obviously, it's very easy for somebody overlooking and in hindsight saying this should have been recorded. And obviously, a first priority of any clinician is the patient. But that is why you can always write in retrospect, and you often see, particularly where things have become an emergency, that a clinician will write in retrospect this happened, and we can pick that up later on in the Q&A with our experts. But that's one of the things that often can be done, is where you haven't had time at the event to write it down, but you simply can write in your notes in retrospect and then set out what happened, because obviously at the time you were dealing with the patient. And just to show the importance of clarity within records, I was recently involved in a trial at the High Court where one of the pivotal points in that trial was a full stop. And that may sound absolutely ridiculous, but the sentence in the medical records was very, very different if there was a full stop in the records as opposed to if there wasn't. And quite a part of that case came down to what it was. So it is just really important just reading through your notes after they've been made, just to make sure they are saying what you're saying. And finally, follow up. If you make a plan for tests or investigations, or if you're aware of someone having a request for different tests for your patient, ensure they're followed up. To not follow up can cause delay in care and also lead to failures. For example, what was the outcome of the test for the GBS? Was it completed or not? And if so, where are the results? This ties into reviewing back through the patient notes, and it becomes clear if the tests have been actioned, because at the end of the day, there's no point huge amounts of work going into somebody doing a test if actually no one's reviewing the records. And time after time, we see in these cases that when you look back in the records, there was a test result that showed that the patient was Group B Strep positive. Okay, so if we flick through the slides down to slide number 5, it will move on to case studies. So what I'm going to do now is just give you the legal perspective and just talk about 2 real cases that we went through. So in this case, this was mum's first pregnancy. She found out that she was pregnant in early 2015 with an early estimated delivery date in January 2016. There were no major concerns during the pregnancy. At 35 plus 1 weeks, mum was admitted with a history of strong suspected rupture of the membranes. She was reviewed by a registrar who planned to give antibiotics immediately and again once in labour. The plan was documented in the records that this was what should happen. Despite this plan, antibiotics were not given once mum was in labour, nor subsequently. Mum was fully dilated by 20 to 10 and commenced active pushing. Sorry, I just lost. 10 minutes later, baby was born in good health, and by 2 minutes past 10, the APGAR scores were 3 at 1 minute, 8 at 5 minutes, and 10 at 10 minutes. Maternal GBS had been confirmed on a swab during her initial admission. But at this point, nobody had actioned anything. And if we move to the next slide, by 5 minutes past 6, grunting, and you'll remember back from what Dr. Rennie said in her talk, was heard, and the baby was transferred to the special SCBU, special care baby unit, at 6:45, where antibiotics were commenced. Despite there being a clear record that mum required antibiotics in labour, this was not communicated and no one reviewed her notes to confirm action or action it. Baby was born slightly premature and mum had not had full antibiotics prescription, but as no one had realised that mum had not had it, they weren't given during labour or post-labour. And unfortunately, this, notwithstanding the treatment that was then provided to the baby suffered severe brain injury as a result of what happened. And in this case, just to reflect back, there were in essence 2 opportunities to be given. Firstly, during labour, antibiotics could have been given, but if antibiotics weren't given during labour, then in accordance with the guidelines, and again, we can pick this up in our Q&A later, antibiotics should have been given immediately after birth. If either of those situations would have occurred, then the infection wouldn't have spread, and the expert evidence would have been that the baby would have survived with uninjured. But unfortunately, in this case, baby was left with severe brain injuries and requiring significant care for the rest of their lives. If we now move on to the next slide, which is the second case study. Mum's second pregnancy, during her first pregnancy, she'd been given antibiotics in labour due to being Group B Strep positive. She raised GBS concerns with the midwife and they said yes, antibiotics were required during labour. Later into the antenatal care, she was advised the opposite. Pregnancy was uncomplicated until she reported on 4 occasions reduced fetal movement, 3 of which were in her 3rd trimester. At 36 weeks, scan was reported as normal. 29th of March 2015, mum had green discharge and reduced fetal movement. She attended hospital, but the CTG was normal. A low vaginal swab was taken and she was advised to be reviewed by the community midwife on the 2nd of April. On the 2nd of April, reduced fetal movement again. So she attends the hospital, and if we move on to the next slide, where a registrar recommends induction. Special care baby unit full at the time, and so she was discharged to return on the 4th of April. On the 4th of April, CTG was normal, but induction still recommended. Unit still didn't have any availability. Daily CTGs and Doppler on the 7th of April was arranged. That night, she suffered with spontaneous rupture of the membranes at 8:15. She attended hospital at 11 o'clock with a CTG was commenced. Reduced fetal movement was reported at 11:30, but CTG was reassuring at 12:15. By 2 in the morning, she was advised that the doctor was busy, so the induction would be the following day. A CTG was performed at 7:30, between 7:30, and 9 o'clock, where it noted decelerations with quick recovery and then normal for 25 minutes. Unfortunately, at this stage, induction of labour was delayed due to staff shortages. The CCG was reviewed by a registrar at 4:10, so literally that afternoon, and it showed 2 shallow decelerations. By 5:45, the CTG chase was suspicious. The registrar plan was to continue and review in 30 minutes, reviewing 30 minutes later, and then she was transferred to the delivery suite at 6:45. The serious untowards investigation report that was undertaken after the incident said that delivery should have been by 7:10 to 7:20 due to suspicious decelerations, but it wasn't. By 8:15, the CTG was suspicious, and by 25 minutes past 8, the CTG was pathological. By 9:20, the fetal heart rate could not be detected, and by a few minutes later, several attempts were made to locate the fetal heart rate, including 3 attempts with FSE. Registrars reviewed at 9:30, and they confirmed an IUD at 36 minutes past 9. The child was born stillborn at 4:20 in the morning. Post-mortem confirmed GBS as the likely cause of death. And if we go to the next slide, please. So what was the breach of duty and what was the causation in this case? So there was an internal hospital investigation found that induction was delayed and that was never occurred as planned. Conclusion was delivery should have occurred earlier. Had it been done, the birth of a live infant would have occurred. This was described in this report as what is known as the Swiss cheese effect, which was an adverse event in that there were repeated failures to communicate the care plan, recognise the need for escalation and lack of situational awareness of previous pregnancy, all following on from each of the vicious cycle. And the conclusion, if we go to the final slide, is in summary, we can identify some simple but common themes, particularly in record keeping, which had they been dealt with, had they been reviewed or looked at and then actioned, these events wouldn't have occurred. And that, along with case studies discussed, show that GBS infection in babies can be reduced, and it's only a small change to practices that can cause it to happen. Thank you for listening to this, and now I'm going to introduce our final speaker of the day, which is Jane Plumb, Chief Executive and founder of Group B Strep Support. She's the Women's Voice Lead for the Royal College of Obstetrics and Gynaecologists. Jane Plumb co-founded Group B Strep Support with her husband Robert in 1996 after their middle child died from Group B Strep infection, and is its Chief Executive. So I'll hand over to Jane. Jane, you're on mute.
Yeah. I've been having 1 or 2 tech problems this afternoon. I do apologise. So you can hear me now?
Yes.
Thank you. Well, firstly, Richard, thank you very much for that lovely introduction. And thank you to Owen Mitchell, particularly to Richard and to Alex Highfield for putting on this brilliant webinar and inviting me to contribute. I've really enjoyed listening to all of the amazing speakers, some of whom have stolen my material, so I'll be able to canter through some of the slides today. Next slide, please. The first time I'd heard of Group B Strep was 27 years ago, after my middle child, Theo, had just died aged 17 hours. And the neonatologist said that they would run some tests, but she thought the cause was Group B Strep infection, and she was right. This picture is one of my most precious pictures. It's of my firstborn Oliver, me holding Theo, and my husband Robert. At that point, we hadn't even heard of Group B Strep. I don't need to tell this audience how awful it was going home without our baby, but with hundreds of questions. When Robert and I found out that Group B Strep infections in babies are usually preventable, we just wanted to stop it happening. So Group B Strep Support was formed. Next slide, please. The charity's aims then and now are to stop Group B Strep infection in babies. And towards that, we provide information and support to families, education and information to health professionals. We push for improvements in UK policy and practice, and we support Group B Strep research. our website holds a wealth of information for new and expectant parents and their health professionals, including leaflets and summary guidelines. If you haven't already, please do check it out. Next slide, please. We're a national charity and we are supported by an independent volunteer medical advisory panel comprising experts in the key disciplines relevant to Group B Strep. And these are the members of that panel. Next slide, please. You've heard a lot about Group B Strep infection today, and Janet shared this graph which nicely shows when babies first show signs of Group B Strep infection, mostly day 1, when they're still likely to be under midwife's care, and that after 3 months of age, Group B Strep infections are very rare indeed. I'm now going to talk a little bit about the guidelines. Next slide, please. The UK National Screening Committee has, since 2003, recommended against routine antenatal screening for Group B Strep, and the National Screening Committee is the body in the UK that determines what screening programmes we have. We at GBSS disagreed with them then, and even more so now, given the huge amount of evidence that's accumulated since then about how screening is better than using risk factors for preventing early onset Group B Strep infection. There was and remains widespread agreement that pregnant women and people whose babies are at higher risk of developing early onset Group B Strep infection should be offered intrapartum antibiotic prophylaxis. So with no national screening programme, can you click please? NICE and the RCOG developed risk-based guidelines to set out who to offer IAP to. Click, please. NICE published its antenatal care guidelines in 2003 and then its neonatal infection guidelines in 2012. Click, please. And the RCOG published their Green Top guideline in 2003. Click, please. And Public Health England, now UXA, published their microbiology standard for how to test for Group B Strep carriage in 2006. Next slide, please. As this audience will know, most developed countries offer antenatal testing for Group B Strep to all pregnant women and people, typically between 35 and 37 weeks gestation, or sometimes 36 and 37 weeks gestation, including all of these countries. And then they offer IV antibiotics in labour to those who test positive for Group B Strep. In the UK, as has been discussed earlier, we use a risk-based approach. Next slide, please. So what's been the impact of all these guidelines? This graph shows the rate of early onset Group B Strep infections per 1,000 live births. So it excludes stillbirth and late onset Group B Strep infections, those that occur between 7 days and 90 days. The dark black line shows the US rate, where they've been offering antenatal testing and IV antibiotics in labour the longest. There has been a major fall since the first guidelines were introduced in 1996, and the rate has stayed low. The grey line shows voluntarily reported data for England. GBS isn't a notifiable disease in England, unlike in the US, so the actual rate will obviously be higher. As you can see, our rate has increased, not fallen, since the risk-based prevention strategy was introduced in 2003. And the red line shows the British Paediatric Surveillance Unit's enhanced surveillance data for the UK and Republic of Ireland. Again, those two data points surveys straddle the time when the UK's risk-based strategy was introduced. So again, they've gone up. So what's happening here in the UK? Next slide, please. Well, a lot of this is likely to be because using risk factors to choose who's offered IV antibiotics in labour isn't as good as testing for reducing early onset Group B strep infection. And there's plenty of evidence that supports this. This 2020 paper reviewed 17 studies comparing test-based or risk-based strategies, covering in total 11 million live births and including 3,798 babies who developed early onset Group B strep infection. It found that screening strategies saw lower rates of early onset Group B strep infection than both risk-based strategies and places where there was no strategies. It also found that screening strategies weren't associated with significantly higher antibiotic use. In the screening strategies, approximately 31% of women were offered IAP, compared with 29% in the risk-based strategies. Next slide, please. So risk-based isn't as effective as test-based strategies, but our rising rates may also be because guidelines aren't being followed very well. We'd certainly been hearing this at GBSS from new and expectant parents. So we used freedom of information requests to ask UK trusts and boards with maternity services about their GBS policies. All 151 organisations that we approached responded, and you can download the full report from our website. Sadly, the findings were quite disappointing. Only 4 out of the 5 trusts had actually updated their guideline since the RCOG published their revised guideline in 2017. Next slide, please. In addition, only half provided information on Group B strep to some pregnant women and people. The RCOG's guideline recommends it should be provided to all pregnant women. And shockingly, 11% said that they wouldn't provide information on Group B strep even when asked. On top of this, half of the trusts didn't offer the option of Group B strep testing to women who had carried Group B strep previously, again against national recommendations. Next slide, please. On top of that, most sites aren't using the recommended ECM technology. Where to take swabs from is key to detecting Group B strep carriage, and it's important that they're taken from both the low vagina and the rectum. Click, please. But only a third of the 136 trusts offering any testing for Group B strep carriage in late pregnancy were actually doing that. 2/3 of them weren't. Next slide, please. Not only were samples not being taken from the recommended sites, the broth enrichment step needed to facilitate the growth of Group B strep was not often used. Only 20 trusts and boards told us that they were using this, so that's just 1 in 8 of the total. So despite the RCOG's 2017 recommendations about when, how and where to look for Group B strep carriage, and Public Health England's standard operating procedure giving details of how to look for it, first published in 2006, few trusts and boards are actually using ECM testing even now. Next slide, please. So what does the future hold? Well, as you've heard, the GBS3 trial is well underway. It's a major trial to get RCT evidence on testing and risk-based approaches for preventing early onset Group B strep infection in a UK setting. It's involving 71 hospitals in England and Wales, 320,000 pregnant women and people and their babies. It was all ready to go and start randomising hospitals to the different trial arms just as the pandemic took hold, and like many non-COVID trials, suffered some delays as a result. However, it's all systems go now. Next slide, please. Within the trial, 36 hospitals are forming the control following the standard UK risk-based approach, and 35 are offering testing to all pregnant women and people. 18 at 35 to 37 weeks of pregnancy using the ECM test, and 17 at the start of labour using PCR tests. Next slide, please. There are broadly three potential outcomes. One is that risk factors are better than testing. 2, there's no difference between risk factors and testing. Or 3, that one or both testing approach is better than risk factors. Frankly, to be anything other than option 3 would fly in the face of all the research that's been done so far. So possible, but not likely. The UK National Screening Committee has committed to updating their recommendation about Group B Strep antenatal screening, taking into account the trial's results. So we hope for a change in GBS policy will be rolled out quite quickly, with a knock-on effect, obviously, to other national guidelines. And we at GBSS will be working very hard to ensure that the information we provide on our website is fully up to date with any changes. Next slide, please. There are other exciting initiatives too. Globally, the World Health Organization has prioritized GBS vaccine development as a high unmet need, and this has attracted significant funding to vaccine developers, along with strong support from the Bill and Melinda Gates Foundation. In 2021, the WHO launched their roadmap to defeat meningitis by 2030, with GBS being one of the 4 key pathogens highlighted. Again, the pandemic has had an impact on the timelines, but we at GBSS were really pleased to help shape the recommendations around Group B Strep. Next slide, please. Vaccines are in development. A maternal vaccine against Group B Strep is the holy grail of Group B Strep prevention. It'll prevent more Group B Strep infections and do it using fewer antibiotics than any other strategy. Qualitative research has suggested it'll be acceptable to pregnant women and people if offered as a routine vaccine, and that it will be affordable if it's priced at £54 or less. And while IV antibiotics in labour is the best we currently have for preventing early onset Group B Strep infection, ultimately everybody wants to decrease Group B Strep infection even more and to decrease antibiotic use. The 2 front runners for a maternal GBS vaccine are Pfizer and Minivax, but even with the increased focus from the WHO and the increased funding, having a safe and effective vaccine against Group B Strep that's routinely available to all pregnant women and people is sadly still some years away, but I can't wait. Next slide, please. In terms of the future of the charity, our key aim remains the same. We want to stop Group B Strep infection in babies, and we will continue to do that, providing information and support to families, education and information to health professionals, pushing for improvements in the UK in terms of policy and practice, and supporting Group B Strep research. Next slide, please. Our website is an important source of information for new and expectant parents and their health professionals, with on average nearly 500,000 visitors a year. We send out free information materials to the NHS. Please make sure that your hospital is using them. We don't even charge postage. Last year, we sent out well over 100,000 of our joint RCOG GBSS leaflets, thousands of our 8-page summaries of their Green Top guideline, which includes a handy flowchart. And we lost count of how many GBS alert stickers were sent out for handheld notes. We also have worked with the RCM to produce an iLearn module on Group B Strep, and they make that free to their members. We hold an annual conference about Group B Strep, and we've literally just this week set the date for next year. So it's going to be 15th of May. Please hold that in your diaries. More information soon. Next slide, please. Our helpline offers information and support to those concerned about or affected by Group B Strep, usually parents, though also health professionals. We don't provide medical advice. We signpost to individuals, healthcare professionals for that. But our team does offer a warm listening ear and provides information and signposts to other services where needed. So if you're getting lots of questions about Group B Strep, then please send people our way and we will be really happy to help. Next slide, please. We'll continue our campaigning for better prevention, identification and treatment of Group B Strep infection in babies. Our current focus is on supporting recruitment for the GBS3 trial, and we continue to push for pregnant women and people and new parents to be provided with accurate, up-to-date information about Group B Strep, including the key signs of Group B Strep infection in babies. Next slide, please. We continue to support research into Group B Strep. We provide a number of trials with patient and public involvement support, ensuring researchers are asking the right questions and focusing on the right topics. We've just started funding research studies of our own, so more about that perhaps at next year's webinar, if I'm invited to that. And we continue to lobby for more research into understudied areas relating to Group B Strep. For example, we know that Black and Asian pregnant women and people are more likely to carry Group B Strep, and their babies are more likely to develop Group B Strep infection, but we don't really understand why. And we're pushing for more research into this area so that we can better protect those at higher risk. Next slide, please. So this has been a whistle-stop tour. Please do visit our website and download more information from there. If you want a really deep dive, you might be interested in this fabulous 3-day virtual conference happening next week in Brazil, and you can sign up to attend free of charge virtually. It promises to be brilliant. I've already mentioned our own annual virtual conference, so this is a reminder to hold the date, 15th of May 2024. Thank you so much for listening, and now back to Richard.
Thanks so much, Jane. Okay, so we're going to move on to our final part of the webinar today, and this is our final question and answer. So we're joined again back by Jane and Rachel, as well as Annette Anderson. Annette Anderson is a midwife who has worked in various leadership roles within maternity services in London. Annette has been head of the early notification clinical team since June 2019. Her role involves providing clinical leadership and strategic direction to the midwives, obstetricians and neonatologists working in the early notification team. Annette's role is extremely varied and involves working nationally within NHS organisations to drive improvement across maternity in line with national ambition, as well as the day-to-day operational management of the early notification scheme. Annette is passionate about improving safety in maternity services, as well as improving the post-incident journey for families and staff. So thank you all. I'm going to go through these questions as quickly as I can, because I'm also very conscious that we are getting to the end of the day, but whilst at the same time we've had a couple of really good questions come through. And just to say to all of our attendees, if we don't get to your question today, then we will send them to our experts and we will ask them to provide their responses in writing that we can then share with everybody as we send out the recording from today. I think one of the first questions that comes, and this is probably a question for Rachel and Annette, would be, would the panel agree that the NHS would save money in repeated tests and efficiency in viewing results if we had a universal way that we could view lab results across the UK?
I can answer.
I guess I'll start with Annette.
I'm a bit croaky, so hopefully you can hear me. Yes, I agree. I think there's lots of ways that we can save money across the NHS. Probably haven't got time for me to get started about why don't we standardise more, but essentially there is a commitment, I think, to improve access to records in terms of digital, and that's outlined as part of the maternity transformation programme plan and also the NHS long-term plan. But yeah, definitely I agree, we could do more.
And Jane, from your side, and forgive me if you don't still do them, if I'm right, your charity provides stickers that they can stick on the front of. I know not all hospitals still use paper records, but a lot still do, or it's a combination of both. But there is a way of highlighting where somebody is GBS. Is that right?
Yeah, absolutely. For the hospitals that still, and for the individuals that use handheld notes, yeah, we provide little alert stickers that can go on the notes, which is a nice visual reminder that Group B Strep is around, and it would be good to ensure the individual is offered IV antibiotics. Increasingly, as hospitals move to electronic patient records, how that is flagged up depends within the system, depends on the system, and there isn't a universal way of doing it. There isn't a standardized way of doing it, which is a real shame. But even in the hospitals where they are using electronic patient records, quite often the pregnant person will have her own notes, so it's quite useful to have on the front of the the pregnant woman's notes, so that they can flag it up, because it's very easy when you're in the, particularly when your first pregnancy, or even when you've done it a few times, for, I don't know, my brain left my body, you may not necessarily remember, whereas if there's a sticker on the front of your notes, it's much easier to remind people.
Brilliant, thank you. And this is specific probably to the report, so again, either for Rachel or Annette, but the question that's been asked is, given a GBS injury code was only introduced on the 1st of April 2020, did you see an increase in cases coded in GBS from 2020 onwards?
Yeah, I can answer that one.
Perfect, thank you.
That's a really good question, and I think that's going to be key for us in going forwards, being able to see what's happening with GBS. The way our cases are coded at NHS resolution, we've not historically had that injury code, so we've been able to code sepsis, meningitis, unwell, lots of generic things, but not specifically for that. And that came in 2020, as you said. When I did the search, actually only one case came through that had that code on it. I think that's not surprising, because these were closed cases. We can't be looking at open cases. And the average time from incident to notification is actually almost 2 years. These aren't early notification cases, these ones. So it takes sometimes up to 2 years and longer for them to be reported. And actually the time from notification to closure is closer to 3 years. So actually I think, although they'll be in the system, we won't see them coming through at this end just yet, but I think we may do in a few years' time. And I think that will be really helpful in picking them all up.
Great, perfect. And one question I guess I had, which it's kind of, once this report data is published, and what's next? What is hoped to be achieved by what is the NHS resolution and NHS's way of what do they want to do next? What's in the pipeline, if you're able to say, in terms of where we go next in terms of this? And I guess that's to Annette or Rachel.
Do you want me to start, Annette?
Yeah, go for it.
Yeah. So I think what we don't want to do is to produce a long list of recommendations that just adds to the myriad of reports that are out there in the maternity sphere at the moment. And a lot of these things are transferable, but I think what we'd like to do is hone in on a few key things that can actually be changed and implemented in trusts. Which is why I think the next step of talking to stakeholders and actually taking advice from those people who are in the field on the ground as to what would be helpful for those trusts would be more important. And we'll certainly have either a report or a did you know leaflet that comes out of this that has that information and the statistics that people can use. And then we'll take advice from the users really as to what will be useful products at the end.
Great. And as Myles has come back on the questions, I've got one question from earlier that we never managed to get to, which I do feel falls within your area, but forgive me if it doesn't, for the spot, which is, if women are GBS positive and the amniotic fluid has been infected with GBS, will this increase the woman's chances of developing an infection herself post-section or post-tear episiotomy through a vaginal birth?
Yes, certainly. Yeah. And I think I mentioned in my talk that we all seem to concentrate on the neonate, unsurprisingly, but the mother can suffer too. And the mum can suffer from sepsis. It's not very common, I admit, but sadly, she can also have chorioamnionitis, and that's a potent cause of stillbirth. So yes, absolutely.
Brilliant, thank you. Well, as we've nicely hit 5 o'clock on the dot, I'm going to take the opportunity to thank very much our entire panel of speakers here and those who spoke earlier, which was Julia, Myles, Janet, Rachel, Annette and Jane. So thank you so much for giving up your time today, because obviously this would not have been possible without all of your support and providing such fantastic presentations. I just want to give, I know a number of people have given a shout out to a couple of things that are upcoming, and when we send hopefully the video out or the recording of today, I'll try and include as many of them as possible, although they will be within the recording itself. If I forget, so do forgive me. I also want to do a shout out for our final one of the series, our Maternity Matters seminars, that we have one coming up on jaundice, which is on the 15th of November 2023, which is all part of the series that we do. And you can also reach out to Owen Mitchell if you want to find out about others that have been recorded and we can play back. But from my point of view, I'd just like to take this opportunity to thank everybody for their time today, and thank you those who have joined us online. And as I say, please feel free to distribute the recording when you receive it to all your colleagues, because the more people that can see this, the more people will be in the know. And yeah, so that's about it. The last thing to say is there is a feedback survey which is available in the question and answer section of today, and I believe will be in the email that you get sent as well. So please do provide any valuable feedback if we can do anything different, because I'm sure that we will hopefully continue this journey next year, hopefully in person, with this GBS seminars. So many thanks all and have a good evening.